right. Hello, everyone. Welcome to this Lunch and Learn, the crisis of addiction. And we're happy to have Phil Snyder from Arrowhead Behavioral Health and Jean Dries from Brightview. Is it Brightview Health, Jean?
It's actually legally Brightview, but we are a health company. Yeah.
Okay, good. And they will be introducing themselves more as they go through their presentations. But I thought we would open with a quick moment of prayer, and then Phil can take it off. So let us pray. Good and gracious God, we thank you for this day, for the beauty of your earth, and for the blessing of rain. We pray that this conversation will be helpful for all of us who are dealing with folks that we know and love who are in the midst of this crisis of addiction. Open our eyes and our minds and our hearts to all that you would have us learn, so that we can be your light and love in the world around us. In your name we pray. Amen.
Amen.
All right, Phil, take it away.
Okay, so I'm going to share my screen here. Can everybody see that?
We can see it.
Okay,
Yeah.
great. So as Sherry mentioned, my name is Phil Snyder. I am a community liaison with Arrowhead Behavioral Health. I've been with Arrowhead now 7.5, almost 8 years. My role is to be out in the community, developing relationships with potential referral sources, healthcare physicians, things of that sort, to educate them on kind of the process and procedures of getting somebody into treatment for either a mental health or a substance abuse disorder. I have served now on the Mental Health Faith Council for just about my entire time at Arrowhead, so about 7-8 years. I also serve as the Vice President of Church Council at Trinity Lutheran Church. So this whole mental health, substance abuse, faith, world is very near and dear to my heart. So, today we're going to talk about addiction and kind of how that is affecting folks. If you guys could give questions throughout the way, throw them in the chat, or I'm not opposed to, unmute yourself and just, tell me to stop. But I think we'll get into it. And so I'm going to share a little bit about addiction, and then Jean Dries, she can introduce herself as well, but we're going to talk a little bit more about local resources and Arrowhead and Jean's with Brightview, how to help folks, loved ones, get into treatment in the Toledo, Lucas County area. So let's move forward, unless anybody has any questions at this point. Seeing none. There we go. So, addiction. So a person with an addiction uses a substance or engages in a behavior for which rewarding effects provide a compelling incentive to repeat that activity, despite any negative consequences. There's evidence that addictive behaviors share key neurobiological features. They intensely involve brain pathways and reward and reinforcement, which involve the neurotransmitter of dopamine. And in keeping with other highly motivated states, they lead to kind of the pruning of your synapses in the prefrontal cortex. So that's, home of, our brain's highest functioning. So that attention is highly focused on cues related to the target substance or activity. It's important to know that such brain changes are reversible after substance use or behavior is discontinued. Substance use disorders do have an increased likelihood of being accompanied by mental health conditions, such as depression and anxiety or other pre-existing problems. Substance use disorder is a complex condition that affects reward, reinforcement, motivation, and memory systems of the brain. They are characterized by impaired control over usage, social impairment, involving the disruption of everyday activities, and our cravings. Continuing use is typically harmful to relationships as well as to obligations at work and school. Another distinguishing feature of addiction is that individuals continue to pursue that activity despite the physical or psychological harm it incurs. Typically, one's tolerance to a substance increases as the body adapts to its presence. Because addiction affects the brain's affective functions, centered in our prefrontal cortex, individuals who develop an addiction may not be aware that their behavior is causing problems for themselves or others. Over time, pursuit of that pleasurable effects of substance or behavior may dominate an individual's activities. All addictions have the capacity to induce a sense of hopelessness and feelings of failure, as well as shame and guilt. But research documents that recovery is the rule as opposed to the exception. There are many routes to recovery. Individuals can achieve improved physical, psychological, and social functioning all on their own, otherwise known as natural recovery. Others benefit from support from community or peer-based networks, and still others opt for clinical-based recovery through the services of credentialed professionals such as Arrowhead and Brightview. The road to recovery is seldom straight. Relapse or recurrence of substance use is common, but definitely not the end of the road. For those who achieve remission of an addiction disorder for 5+ years, researchers report the likelihood of relapse is no greater than that among the general population. Addiction does come in many forms. I guess at this time, if we were all together, I'd just have you shout out. But if you want to throw in the chat or even unmute, and maybe give me some examples of addiction, see the chat with me, shared screen, but maybe just shout them out.
You want examples of addiction?
Yeah, like what different forms of, there's obviously alcohol,
drugs and alcohol and food and
gambling.
Any others?
Money, shopping, power.
Ooh, I like that one. I don't know that I've thought of that one. Here's, I listed a few. I think we hit every one of those. My addictions, primarily pizza. So that falls in the food category. But around the world and in the US, nicotine is most widely used and addictive substance. Tobacco causes a reported 40 million deaths worldwide. According to the National Institute of Drug Abuse, smoking kills more than 1,000 Americans every day. And although tobacco use is generally declining in the US, its use is increasing among our young, especially in the form of vaping or inhaling nicotine vapors. We also talked about alcohol. Alcohol in some forms is widely used for pleasurable purposes and is an important part of the social fabric worldwide. Nevertheless, according to the National Institute on Alcohol Abuse and Alcoholism, 14.6 million US adults over the age of 18 have an alcohol use disorder, marked by uncontrolled drinking. Around the world, 240 million people are reportedly dependent on alcohol. Alcohol abuse is most prevalent in Eastern Europe and least prevalent among Asians. That was an interesting tidbit. So Painkillers, including prescription opiates, such as oxycodone and fentanyl, as well as heroin, account for more than 10% of all addictions in the US, affecting more than 2.5 million people. Cocaine is a stimulant that is often snorted and injected intravenously, but is considered to have the most potential for addiction because of the fast, intense high when smoked in the form of crack. Other stimulants that are subject to abuse are amphetamines, widely prescribed to combat ADHD and to foster alertness and energy. Depressive agents such as sedatives and tranquilizers are widely used medically to combat stress, anxiety, sleep disorders. But NIDA reports that 3.5% to 5% of the population use tranquilizers or sleeping pills non-medically. So
if I may be picky, is the presence of detrimental consequences a necessary part of the definition of addiction? You mentioned pizza, for instance, and I'm not aware of any detrimental consequences of ingesting pizza, depending on how you ingest it, of course. And I wonder about casual use of addiction, making it more difficult to understand the reality of it when people talk about being addicted to chocolate, say.
So I guess to answer your question, I mean, I could see pizza, to some degree being detrimental. If you consume carbs, in excess, as far as health, related. What was, I guess I didn't get your.
Well, the previous screen,
it said jump in as well.
Previous screen referred to negative consequences of using the substance.
Mm-hmm.
Detrimental consequences. Just about anything we do, if done to excess, can have detrimental consequences.
Absolutely.
So in that sense, I could argue that I'm addicted to oxygen because if I overdo it, I get dizzy and pass out. Same with shopping on this list. If we don't shop for at least some things, all kinds of detrimental consequences. If we don't shop for clothing, we get arrested for indecent exposure. And I wonder about casual use of addiction, making it harder to understand the reality of addiction.
Okay. I mean, obviously, if we need food, we need water, we need oxygen to survive. Absolutely, casually gambling, casual use of alcohol isn't detrimental in that sense. It becomes detrimental when it becomes something that you overuse or use in excess, where it then hinders your I guess ability to perform everyday life. If that answers your question at all. Sherry, you're the social worker.
Yeah, it's definitely the inhibition of regular functioning behaviors and relationships with others. When relationships are crumbling, when there's loss. We talk about hitting rock bottom. You've literally lost your job, your relationships, bankruptcy. You're at the bottom because all of that normal behavioral functioning has been challenged and broken in many, many different ways.
So suppose I said, I'm not responsible for my outrageous behavior because I am a sex addict, and it's the addiction that is the problem, not decisions that I'm making.
that's part of the healing process, right? Is to be able to become, I mean, part of intervention and therapy is to take responsibility for your behaviors. And any AA or 12-step program is about coming to that realization that this addiction is beyond your control. And so I just kind of, it's beyond your control, but you're responsible for your behaviors and the responsibility of realizing where you are in this process, and that this addiction, whether it's shopping or alcohol or food, is inhibiting your ability to function in life. And then you can take steps towards healing. And I would think Jean and Phil, you could answer this better than I can.
Yeah.
Thank you, Sherry. That helps.
Yeah, I think it's a good question. I think you answered it really well. Again, it's to his point, some of this is normal behavior. It's when it becomes abnormal behavior and extreme, and consequences, as he pointed out, often come with these choices that they're making. And hence, some of what we'll talk about, it's hard to do alone. It can be done. And that's why we'll get into the MAT and the various clinical and medical resources that we offer, because, you know, some of this is challenging to do alone, but we'll go through that. But I thought the question was great. I'll give it back to Phil.
Thank you.
Perfect. Thanks, guys. So, you know, different causes of addiction. Addiction is really a multifaceted condition, you know, and it rises from many elements. So there's really no way to predict who will develop a compulsive substance use behavior. It's more accurate to really think of risk factors for the development of substance use disorders rather than those direct causes. So we're going to dive in a little bit deeper into some of the biological, psychological, and environmental factors associated with addiction. So biology contributes to addiction in many ways. How the body metabolizes or breaks down and eliminates foreign substances such as drugs or alcohol is heavily dependent on the presence of various enzymes, and they may vary significantly between individuals and even between different ethnic groups. Our genes, it's estimated that genetic factors contribute to about half of the risk for developing a substance use disorder. Physiological factors, you know, the variations in liver enzymes that metabolizes those substances are known to influence one's risk, as well as gender. Males are more likely to develop a substance use disorder than females, although that so-called gender gap may be narrowing more in the alcohol use disorder. And I guess to touch a little bit more on alcohol use disorder, alcohol is a brain depressant, and alcohol use disorder is common, although, like I said, more among adult men at about 12.5% than women at nearly 5%, although rates are on the rise for women. It affects men and women differently. Women seem to be more susceptible to some of the detrimental effects of alcohol. And most commonly, this alcohol use disorder develops well before the age of 40 for most. Psychological factors, you know, our personality, you know, both impulsivity and sensation seeking personalities have been linked to substance use disorder. Early exposure to significant adverse experiences can contribute to the development of substance use disorders by overwhelming an individual's coping ability. Adverse childhood experiences, otherwise known as ACEs, and I know that I believe last year we had, you know, Jennifer Wolf spoke a little more in depth on the ACEs study. But, you know, ACEs kind of studies more in the trauma, especially combined with an unpredictable, chaotic childhood. You know, this poses a risk factor to many kinds of behaviors and poor health outcomes. Studies show that have individuals with multiple ACEs puts children at risk of poor school performance, unemployment, high-risk health behaviors, including smoking and drug use. Some of our environmental factors, you know, include, you know, the family. So while strong family relationships have been shown to protect against substance use disorders, several aspects of family functioning or circumstances can contribute to that addiction risk, such as having a parent or sibling in the household with an addictive disorder, or lack of parental support or supervision, poor quality or troubled parent-child relations, as well as sexual, physical, or emotional abuse, all add to you know, increasing that risk of an addictive disorder. Research does show that marriage and child raising responsibilities do mitigate that risk. However, you know, it is unfortunately still prevalent, you know, with those that are in a family, married, you know, child situation. Accessibility, easy accessibility of alcohol and other substances in one's home or your community or at school or work have shown to increase the risk of repeated use. So highly recommend that we lock up our liquor cabinets, we lock up our medicine cabinets. We hear way too often of individuals that visit your home that have access to prescription medication or alcohol, you know, tend to you know, subject you to, you know, some of that assistance in their addiction, I guess. As profoundly social beings, you know, we're strongly influenced by our peers, and we seek to be liked by them. So we may adapt many of their peer behaviors, particularly during adolescence. You know, we're still molding our needs and wants and desires, and we tend to kind of follow the pack. So positive social relationships are known to strongly protect against substance use. And then having a job and developing skills for employment definitely mitigates, you know, the addiction risk. You know, it provides for some financial security, some psychological rewards. So, you know, those that are working and are being counted on for providing for their families, you know, tend to not have as high a risk as those that are sitting at home and are isolated and you know, kind of alone. So we do want to talk, you know, the world that we live in right now, you know, with masks and you know, social distancing. We wanted to talk a little bit about how COVID-19 has affected addiction. Certainly we've seen an increase in drug and alcohol use and abuse. Specifically, there's been a resurgence and an increase in opioid use. Opioids are drugs that include heroin, prescription pain relievers such as oxycodone, codeine, morphine, and fentanyl. According to the American Society of Addiction Medicine, 2 million people have a substance abuse or use disorder involving prescription pain relievers. And nearly 600,000 have a substance use disorder involving heroin. Opioid-related overdoses are now the leading cause of death in Americans under the age of 50. And we have seen according to the CDC, in the 12-month period ending in May of 2020, we saw over 81,000 overdose deaths. That's the highest total in our nation's history. Reports are still coming out, but I have to assume that number is going to rise as we continued through the pandemic and through 2020. The CDC attributes the surge in drug overdose deaths to the disruption of daily life created by the pandemic. During this time, we saw a 54% increase in alcohol sales in the month of March of 2020. Overall, it was closer to a 10% increase in alcohol sales in 2020 versus 2019. So people are at home, they're isolated, they're seeking alcohol as more of that coping skill to get through the day's stresses. Mental health experts also cite reasons for increased alcohol use and legal and illegal drug use during the pandemic. The confinement of lockdown and fear of illness have dramatically increased the prevalence of and intensity of anxiety-related and other mental health disorders. For example, a survey of people with obsessive compulsive disorder found that 72% experienced an increase in symptoms. By restricting activity, curtailing social life, and limiting access to usual sources of pleasure, confinement magnifies those psychological distress of many kinds. For many, the pandemic has caused deep suffering, directly linked to increased substance use, loss of loved ones, loss of job, loss of income. Social isolation has certainly increased that substance use during this time. Also, at the same time, this to me seems a little odd, but being employed has created some problems and stresses for families, burdening parents with the stresses of schooling children. They've gone from working out of the home to becoming teachers, keeping their kids occupied and motivated, without the absence of kind of their peer contacts. They now have to prepare 3 meals a day, as opposed to relying on the school to take care of a few meals, on top of their ordinary parenting demands, all, like I said, while trying to work themselves, whether that's outside of the home and working at their place of employment, or restructuring their home so they can be home and working remotely. We've seen through the pandemic that it may be more observed as really 2 pandemics, the COVID-19 one, which is more of the health related, and then also the mental health crisis that it has set off. So, cumulative burden of real losses, restricted life, worry, and loss of social outlets challenges even those with the best coping skills and coping resources. So for some time, the stresses are so overwhelming that they turn to unhealthy sources of relief. The good news is that that substance use is treatable, and it's complete remission is entirely possible. Recovery does happen. However, it's more of a long-term process that may involve multiple attempts. Anyone that's suffering with a mental illness or an addiction, it's not like you break your arm, you go to the ER, they set it, put you in a cast, and 6 weeks later you're cured. This is a lifelong battle that many have to deal with. We're seeing now too that relapse is part of the process. An effective treatment regimen addresses, the prevention and management of recurrent use, but it's no longer frowned upon when somebody relapses. It's since success tends to not occur all at once. Any improvements are considered important signs of progress. Increasingly, programs are available to help those who recognize that they do have a substance use problem. Which leads us into, we have amazing resources here in Lucas County. Just to name a few, the Lucas County Mental Health and Recovery Services Board is really the governing body in Northwest Ohio in regards to providing treatment resources, education, and linkage to the resources within our community mental health agencies. Also blessed to have an amazing NAMI, which stands for NAMI of National Alliance on Mental Illness, where they provide a number of mental health resources, family support groups, creative expressions, activities. They also have family navigators that can help individuals and families navigate, the world of mental health. Robin will like this plug. So there is, coming up on May 22nd, we do have the NAMI Walk, which is an annual fundraising effort, which allows NAMI to provide all of these great resources at no cost to our community. And then we also have a couple of private companies, Arrowhead Behavioral Health, which I represent, as well as Brightview Health, which is available for folks suffering from an addiction. So I'm going to have Jean take it away. Does anybody have any questions at this point on the addiction piece? We're going to talk a little bit more now on the local resources.
Bill?
Yes.
I do have a question or a comment. Actually, 2 weeks from today, I'm going to be bringing my grandson to Arrowhead for treatment. He is being released from Lebanon prison. He's been in there for 6 years, and he is addicted at the moment to Suboxone.
Okay.
So he's going to be coming to Arrowhead to get detoxed. He's under the impression that he will detox and then get a prescription for Suboxone, and then get the Vivitrol shot.
Okay.
So is any of that kosher? I wouldn't think that he could get prescription to Suboxone, but at this point, I'm not going to tell him he's not.
Right.
Because I don't want him to get overwhelmed.
Yeah. Each individual case is different, and I'm not the clinician. So, once he comes and meets with our clinical staff, they'll make that determination. There may be a need for, a titration and, for him to get off of that Suboxone and move more towards the Vivitrol.
Okay.
But that's entirely up to,
during his
the physician and the clinical staff to determine that. I think that's all possible.
Okay. And then when he's done with his detox, he's going to go to Napoleon to Renewed Minds Treatment Center.
Okay.
And be assessed there as well. So I appreciate Arrowhead being there for him.
That's great. Yeah, it's a total collaborative effort. You know, every facility, every treatment option is different. They all, I guess, specialize in different things. So it's really important to connect those individuals with, you know, the proper level of treatment, and then to work together, and, you know, on that continuum of care, whether it's, like I said, at Arrowhead or Brightview or Even Need Mind. The key is that communication piece and getting them in the right place at the right time. So,
Sure.
awesome.
He started out as a heroin addict, and then resulted in incarceration.
That is the road many take.
Yep.
So
yeah.
And I've seen many successes. So
yeah, and unfortunately, and I'm still not sure how they can get Suboxone when they're in prison, but it happens. So
they're very, very resourceful. So
yeah. I'm finding that out. So
all right. Any additional questions before I turn it over to Jean? All right.
Okay. Thanks, Phil, and good morning, I guess almost afternoon, everyone. I know that Sherry sent out kind of a quick bio, but I've been with Brightview a little over 2 years, which is when they joined the market up here in Northwest Ohio. Previous to that, I was with Harbor Behavioral, as Robin knows, who I know is on the call, for about 10 years. So appreciate your time. And Phil's going to be so kind. He's controlling the PowerPoint. And I think he did a great job kind of setting the stage on addiction in general. So before I talk about this slide though, Sherry and Robin, I know you're both on the call, and could one of you put in the chat or forward the email to the Faith Council, the alcohol forum that we're conducting tomorrow at noon. It's free to everyone, noon to 1. It's being led by our chief medical and chief clinical officers. And we have folks joining us from all over the state. And it's on alcohol and best treatments, and kind of goes into more detail on what Phil was touching on, that, you know, there's all kinds of addictions, but when you get down to it, alcohol is right there at the top of the list, and it affects so many people. And so we're going to step through best practices and how to refer, and you know, what a functioning alcoholic might look like if you're not familiar with what that might look like and present. So again, I don't know, Sherry or Robin, if you can drop it in the chat for me while I'm talking, or just forward the email. You just have to hit the hot link and register. Again, a Zoom call tomorrow, noon to 1, that we're conducting in Alcohol Awareness Month to everyone. So hope you can join us. Not too late to sign up. So back to let's disrupt the cycle in Brightview. I'll just kind of focus on this slide, try and keep it a little quick and high level, but the system has not, in some cases, worked very effectively in history. There's been a lot of barriers. Typical barriers were insurance, taken or not taken, access to care, transportation. So Dr. Ryan and Dr. Kang, who are our two leaders, basically, let me just back up for a minute and tell you, they came out of the Mercy Health system. Dr. Navdeep Kang was the chief clinical officer for all of Mercy Health Bon Secours, and Dr. Ryan is still an emergency room physician and a substance use expert. And they decided that they wanted to form Brightview with Mercy's blessing and make a difference in this crazy world that we live in of substance use disorder, and try to disrupt these cycles and the dysfunction that was happening where people were falling in and out of treatment. So they both sit on the governor's task force. It's called the Recovery Council. And actually, they do more work, I think, nationally than even in the state anymore. I know Dr. Ryan was one of 5 that was called into Washington, D.C. to give testimony on where he thought the billions of dollars should go regarding the lawsuit settlements with the OxyContin and abuses that took place that led to part of this crisis. So to have both those guys do the forum tomorrow, I'm pretty excited. They're extremely knowledgeable. And Dr. Kang is also Obama fellow. He was chosen when Obama was president to lead the whole vision on substance use mental health across the country. So that was kind of cool. So having those guys talk tomorrow, if you're free, that'd be great. But again, back to my slide, I digress. You know, I'm not going to read to you. These are some of the points on Brightview. I touched on disrupting the cycle. I think the key one that's bolded is where I'd like to go. Everybody takes walk-ins now, and there's various things that are commonplace. But if you want help, you can get in today at Brightview, even if you're uninsured. I think that's pretty amazing. And coming from an administrative role previously, you know, you need to be very careful on what happens on day one. Doing paperwork and then getting an appointment 3 weeks later for help is not going to help someone who's in addiction. So we talk about they will see the medical professional, the clinical staff, the peer support team all within 4 hours of the day they present, and that's a promise, even if they're uninsured. So we're pretty focused on treatment on demand, and getting anyone that's close to this industry knows if they're not mandated to us through the courts, which happens all the time, when someone actually, however they get there, wants and seeks help, they need some appointment immediately to engage them. Anything short of that could lead to death or bad decisions. So how can we remove barriers? Again, talked about the time sensitivity of this whole SUD crisis. And like this says, some of this is a matter of life and death. And we lead by best practices, best medical practices, as I'm sure Arrowhead, I know they do as well, and on what works and what doesn't work. Because ultimately all the insurance companies are involved and the criminal justice, you touched on the criminal justice system. Everybody wants outcomes and they want better solutions, and they want people to go into recovery and regain a functioning, productive life. So those are kind of the things that are guiding the decisions that we're making. And again, being led by an emergency room physician who saw this epidemic down in Cincinnati years ago come to fruition to the point that he started a company, I think will always guide our best medical practices. So again, I'm trying to get people help when they need it. Phil touched on COVID-19. I won't spend too much time on this slide because of it, but it did us no favors. And I think everybody on the call and anyone in the world would understand that. I know I serve on the board with Robin for NAMI here in Toledo. I'm on the board of trustees. We were talking about this last night, about how pertinent mental health has become to people and how more and more people are needing assistance due to all the things that Phil was talking about on his slides. And oftentimes mental health and substance use disorder go hand in hand. So again, it's about getting people treatment and or encouraging them to ask for help so that we can get them treatment in their, I know that's what NAMI is all about, and all of us in the provider industry, about knocking down the stigma. If you came to, I'm going to jump to just a comment. If you came to a Brightview center, and we're now the leading provider across the state of Ohio, we have 28 centers, and we just opened 8 in Kentucky, and we're just growing exponentially. And I think that's partially due to the way that we treat people and the fact that we can deliver outcomes. The way we treat people is probably what motivates me the most, which again is treating people with dignity and respect, calling them by their name and greeting them in our waiting rooms, thanking them for coming in, encouraging them on their path to recovery, understanding relapse is part of this. And again, our peer support people do a great job when they do relapse of re-engaging them and meeting people where they're at so that they don't fall out of treatment. So medical best practices, none of this is new. We've known for a long time what the Surgeon General and people believe is the proper treatment. And so again, that is what guides us in our best medical practices and in our best clinical approach, peer support being a huge part of that. Phil, can you jump back one slide, please? Sorry about that. And then the types of MAT, I don't think it's, we call it MAT. I hate acronyms if you're not in our industry, but you've probably heard about these. These are all medical solutions or options for people to help them step down. We were just talking about one a minute ago. Suboxone is in that category of buprenorphine. but there's methadone, there's Vivitrol shots, very, very expensive, but you don't need them as often. Phil is absolutely right. Some people will need this assistance, some won't. And that's all determined by our medical team upon assessment. And, you know, really, Dr. Ryan and I have done a lot of TV and media appearances, and he says a couple things that always resonate with me, which is, you know, really, this isn't all that complicated. You need to know what they're using and how long they've been using it. And by the way, we run our own toxicology, we run our own labs at Brightview, because what people think they're using or say they're using, no offense to people, is usually wrong, either through ignorance or perhaps a hair of deceit. So until you know what medically is in their system, you cannot really put the right treatment program together for them. So we have lots of fun discussions with insurance companies about why we run our toxicology so deep. And that's partially because the illegal substances might also interact with the legal substances someone is taking, and you need to make sure you're fully aware of that when you're dosing and prescribing the medical procedures. So just some things there. Those are the common words that you've probably heard: Vivitrol, Suboxone, methadone. Again, are all versions of MAT or MAT that help people step down from true addiction. And then again, to the point of the gal that shared about Suboxone and her family, yeah, there are ways to wean people off of Suboxone, and that is something that does come up all the time. There's also ways to wean people off of methadone. A lot of people in this area are on super high doses of methadone. I get calls from the Cherry Street Mission and places all day long that just say they're dosed and they sit here all day, Jean. This is not a path to recovery. So again, we've written a medical protocol, Dr. Ryan has, that we're sharing across the state now on how to safely bring someone down off of these incredibly high doses of methadone that they somehow got put on. So very complicated, and thank goodness I'm not making any of these decisions, because these are all medical decisions that need to be made on administering these drugs. Okay, back to the next slide. Thanks, Phil. So again, clinical best practices, again, it's all about a treatment team. I know that Arrowhead is similar in this philosophy. All of our counselors are mastered level social work with trauma-informed care training across all of our centers. You cannot resolve this if you don't dive into the social and the psychological and all the things that are driving someone to have a substance use disorder. And of course, that includes mental health. You can just go back and forth. They have depression, so they're using a drug, or they're using a drug and now they're depressed. It's all very intertwined. So that clinical piece is incredibly important to have in the treatment plan. And, you know, we asked questions like this. Dr. Kang, as I mentioned, that came over from Mercy Health, the last thing we ask somebody in an assessment is, do you have a place you're sleeping tonight, and do you have food? So back to all the social determinants of health and what we know have to be solved also to have somebody be compliant in a treatment program. Those pieces are asked by our social workers and case managers. So very good stuff going on. We're evidence-based. I commented on that. Does it work? This is probably my favorite slide, only because it's fairly new from Brightview. But with over 8,000 people in our outpatient treatment centers now, we have enough data and we're willing to share it. And again, Dr. Ryan and Dr. Kang work with the insurance panel for the state, because pressure is being put on insurances that are putting pressure then on patients or people like us that serve patients to produce outcomes, meaning a clinician can't write a note for 8 years and say that Mary still comes to her and talks about her life issues, and the treatment plan isn't showing how we're exiting Mary off of seeing someone and getting her functionally back into the world. So those progress notes and the diagnoses and trying to put parameters around, similar to what insurance companies have forced on, like a knee replacement surgery in the bell curve, the same is happening in our industry. There will always be exceptions to the rule, but again, what would a insurance company be willing to pay for a diagnosis of, I'm making this up, cocaine use, substance use disorder as a primary diagnosis with a secondary diagnosis of depression? What would that look like? How long would that take? What are you doing, and how are you getting outcomes? to help that person move on. And then that allows obviously people that provide services to work with new people and not just have a caseload that carries for several years. So again, I won't read the stats here, but pretty exciting stuff that we can come forward with data points based on being the leading provider and say to people, I was on the chamber task force yesterday, you know, we can't hire people right now because partially because they don't want to work maybe for other reasons, but they go to a job interview, then we mentioned they're going to take a drug screen, and the 25 candidates become 6 that return for the drug screen, knowing that they're not going to pass it, that they have a substance probably that will show in their system. So again, working across all these various agencies, this is a problem that's complex and that we all have to work together to get a workforce back in line and to help people get on with their lives. Supporting local communities. Yeah, we're all working together to save lives and serving patients and clients. Our new tagline that's been rolled out, which I did not think of, but I think it's brilliant, is simple. It's serving people, saving lives. And that is really what fundamentally drove us to start Brightview. Was Dr. Ryan could not take any more of somebody waving a pamphlet to somebody who presented in the emergency room, waving a pamphlet and saying, I hope you get treatment, knowing that that person could well die or end up in the criminal justice system. So again, we've got to do a better job linking people from all these key areas into outpatient treatment. So real quick, just to clarify, Phil and Arrowhead, wonderful partners. They do inpatient. That's usually the starting point. A lot of people do need inpatient, especially if it's alcohol and they're going to C's and you need a nurse 24/7. But regardless of where you enter into treatment, we put our footprint on long-term quality outpatient care because everybody's going to need that. And again, it's where a bulk of people will spend most of their recovery time, is not in a hospital ED or even in inpatient or detox centers. It's in the long journey of life, as we kind of alluded to keep them in recovery and working with them when they do relapse to pick it up and start again. So that's kind of why we decided to go into outpatient only. A lot of people ask, will you do inpatient? Are you going to get into residential housing? At this time, that is not Brightview's goal. We're just going to keep trying to do the best job we can with outpatient treatment for folks. And again, to the alcohol that I alluded to, there's so many people that just can't disrupt their lives, right? They are functioning alcoholics going to work every day or paying the bills for the family. And the same can be true even of other substances. So it's just not an option for them to check out of life. And of course, every treatment option, you just try to find the best solution for that person because the goals are all the same. What is going to work and what are they going to stay compliant with? So that's kind of a lot of words kind of to this slide, but supporting the local community. I'm going to jump back 1 second, Phil, just won't read it, but you know, all of that stuff is there. We're currently working with hospital systems across the state. Dr. Ryan is leading that charge for the healing community to get them to start some of these best practices in the emergency room and then do the hot handoff to providers. That is a proven best practice. So a lot of things are changing, again, on embracing people and working together to start a treatment plan, maybe in an ED or in the jails and prisons, as we talked about. And then what does that look like when they step out back into the real world? So, okay, sorry, next slide. So virtual world, quickly, I will say we were doing virtual mental health, telehealth, whatever you want to call it, long before COVID. That was just something that we saw as an emerging trend. And I think everybody who's been Zooming for the past year understands that this, no matter what industry you're in, it's probably never going to go away. And they just keep pushing the envelope to see what can be done successfully virtually because it seems to work better for a lot of different people, not for everyone. But again, there's all kinds of data points about who likes it, who doesn't, where is it most appropriate, et cetera. But it is here to stay. And for SUD, substance use disorder treatment, it's a key part of our formula. It allows us that immediate access to care because we don't know if 22 people are going to appear in Lima today or Mansfield or Cincinnati or Maumee. We can move our resources around quickly for immediate assessments. We do the same with our peer support people because peer support people are critical, but people bond more with someone who had a similar experience. So if I use the example, if someone has an alcohol use disorder, they're probably going to be better embraced by those that are being treated for alcohol abuse versus someone who's come through a heroin addiction. So we can balance our peer support people too, to kind of cement that relationship and make sure that that clicks, because it's got to work for the person in treatment. Other couple things, I guess I'd say quickly on virtual world, we've put together the first virtual model that I'm familiar with. It might be the first in the country. It's certainly the first in Ohio, where we have put together for the underserved surrounding markets a virtual approach, which even includes collecting urine and samples from people. And they might not even have to step foot into our center, which is amazing. As much as we're growing, there are just certain markets you can't hire the right staff in a brick and mortar building. So a lot of compliance issues went around that, but that just launched about a month ago. But what we're seeing in our physical buildings is what I call the hybrid model, which again is where someone comes in initially, gets assessed, drops a specimen, meets their treatment team. But if they live in Bryan, Ohio, they might well want to do much of their work virtually with their clinician, their peer support groups, all of that stuff, and only come over to Maumee, Ohio, once every month or once every couple months, which again keeps people more compliant, especially if they have transportation issues and other things going on in their life. So the virtual world is here to stay. We've pushed 100% virtual. The hybrid model is what we use in most of our centers. But I will say, if somebody wants to be seen face-to-face every single time, they can be seen face-to-face every single time. Again, it's whatever's going to work for them to keep them on a path to recovery. Okay, quick, next slide. And so again, 3 easy ways to refer. I'd be remiss probably not to touch on this. We have a 24/7 hotline. So we get calls from prisons, jails, hospitals, people at 2 a.m. Saturday night. Someone will answer that phone and schedule them for the first available, which would be Monday morning if it comes in on the weekend. And a majority of the people answering our hotline, part of our engagement strategy, is people in long-term recovery. So again, if people don't feel heard, embraced, listened to, encouraged, many people dial a call center, and if they feel like a number, they'll just hang up. They'll never even get on the books. So very cognizant approach on what that touch is like when someone, be it a referral partner or someone individually looking for help, calls in and tries to set up an appointment. But we'll get them in same day or next day. That's a promise. Online, another thing we just launched, which is being received just in a huge way, which doesn't really surprise me, is online appointment setting. As good as a call center is, we've now got a technology on our website where you can go online. Discharge planners use this all day long, prison systems, jails, lots of different people go out and schedule for the week. They look at their caseload and say, I got 10 people that are going to be released. I got 10 people, in inpatient, they're going to get released. They need quality outpatient. They go online and set an appointment, and it's super easy to navigate. And the way we buffer that is you can do a same day appointment with a 2-hour buffer, because we know it could roughly take 2 hours for them to physically get to the center. So even emergency rooms will pull up the online scheduling tool, have someone they're going to let out of the ED at 11 a.m. They'll set them up with a 1 p.m. that day, and we'll help arrange transportation to get them over to us. And then walk-ins, a huge industry change. It started about when I was at Harbor. It's huge now, which is, again, back to access of care. I think I had 4 people today. They just simply walk in. They didn't schedule. They didn't go online. They just walk in. They could be drunk. They could be high. They could be in precipitated withdrawal. And we embrace them, and we will see them same day and get them a team immediately. So that's a big part of the business too. You never know when someone might want help and what motivates them. So that is a quick overview of Brightview. Thanks. I saw something popping in the chat. It looks like Sherry's going to put our alcohol summit in the, or email it out. So again, Dr. Ryan and Dr. Kang are leading that for the state tomorrow, 12 to 1. But I think we all need to remember, as much as we've talked about heroin and addiction, that Phil hit the nose on the head. Tobacco and alcohol are right at the top of the list of people misusing a substance. So that is my presentation. Any quick questions for anyone? From anyone, I'd be happy to answer them. I see, I'm gonna go in the chat. I don't think there's any questions, Sherry, or Phil, do you see anything? I do not.
Nope, I don't think so.
Okay, so again,
Thank you.
I guess thanks for your time and attention. And if we can help anyone or you have someone struggling, please check Brightview out. I just want to keep people on the right path. Thanks.
Thank you.
Okay, thanks, Jean. I'm going to give you a quick 10-cent tour of Arrowhead and how to gain access to treatment at our facility, and then we will get you guys back to work or whatever you have planned on this beautiful Thursday afternoon. So Arrowhead is a 48-bed psychiatric hospital, drug alcohol detox treatment facility. We're located in NAMI. We provide behavioral health and addiction services for individuals 18 and over. We're in a private, newly renovated facility located in Arrowhead Park. We offer, a little different than Jean. We're more on the little higher acuity. So we offer inpatient services and inpatient acute psychiatric hospitalization. So anybody that's suffering from an acute mental health crisis, suicidal ideation, homicidal, acute depression, anxiety, PTSD, trauma, they're in good care and need more of an inpatient setting. We're available for that. We also offer, so we have 14 beds that treat just straight psychiatric crisis. Our other 34 beds are more of a dual diagnosis. So a program designed for patients with both a mental health as well as a substance use disorder. We also offer a detox program for folks primarily from alcohol, opiates, and benzodiazepines. Typically are not going to admit somebody for cocaine or meth use unless they have an underlying mental health disorder. In addition to that, we do offer up to a 28-day chemical dependency rehab program. All of these services, we're providing, some group instruction, a 4-week kind of treatment program is put in place for individuals. We try to individualize it as much as we can, although we see a lot of success in the group setting. We do offer 12-step groups as well as wellness education, some yoga, low impact aerobics. We try to institute spirituality wherever it's accepted. Family involvement is extremely important as well. Unfortunately, through the past year with the COVID pandemic, we have not allowed visitors into our facility. So we try to do our best virtually, I guess, with connecting our individuals with their family and ongoing supports. Like Jean had mentioned, we do offer medication-assisted treatment as well, an initial Vivitrol shot, as well as an ongoing Suboxone maintenance program. In addition to our inpatient services, we do offer, outpatient as well. A partial hospitalization program is for adults with a mental health or a substance abuse issue, and they're provided immediate access to that transitional level of care. It can either be a step down from our inpatient or a standalone level. They can come in the front door right into that program. That program meets 5 days a week, 6 hours a day. Very similar in treatment as our inpatient, where they go home at the end of the day. We also offer an intensive outpatient program for our substance abuse disorder clients. This is typically a 6-week program. We do accommodate their schedule. We have a morning and an evening group, and they meet 3 days a week, 3 hours a day. We also offer a relapse prevention. So anybody that has gone through a program at Arrowhead are welcome to continue in this relapse prevention group. It allows them to stay connected with peers and helps them stay engaged in their recovery. One of our specialty programs is that we do offer an impaired professional program. So we're certified by the Ohio Medical and Ohio Dental boards to provide confidential treatment for impaired professionals, those that have a license at stake. Unfortunately, there's added stresses to maybe being a doctor or a nurse. They have access, kind of like I spoke about earlier, access to prescription medications. And unfortunately, from time to time, we do see our professionals that develop an addiction disorder. So the medical board and dental board have instituted a 1-bite rule where those professionals can seek treatment. It's up to a 28-day program. It's entirely, totally confidential. They come in under a separate name. That way it can't be tracked. As long as they complete the program, they do not, lose their license. If they opt out or continue use, then they're subject to losing their license. Financial arrangements, we accept all major insurances. Up until about 2017, we only accepted Medicare and commercial insurance. We changed the rule back in 2017 for private facilities like ourselves to accept Medicaid. So there's no reason, especially funding, for anybody to not be able to get into treatment these days. So it's important to contact our intake department, which is available 24/7. We're staffed by master's level clinicians, and they complete a full psychosocial evaluation and then consult with one of our 5 psychiatrists to make a recommendation on level, the appropriate level of care that meets that individual's need. So individuals can come to us, kind of like Jean was talking. They can call, they can schedule an appointment, they can walk in the front door, just like you would at your local ER, and they'll be evaluated, and we can get them admitted into one of our programs. If for some reason they don't meet qualification for one of our programs, that's where it's extremely valuable for us to develop rich community partners, such as, we work with Brightview quite a bit. If somebody doesn't meet inpatient need, we can get them connected to treatment in the community, whether it's at a different detox facility, at private counseling, somewhere. We're going to meet them where they're at and provide the best possible resource for them. So that was quick. I could certainly go into a lot more detail on the services that we do provide, but Arrowhead's been around for about 20 years now in the Northwest Ohio area. We're available to meet your needs. Anyone have any additional questions for us today?
Phil, are your psychiatrists, you said you have 5, are they full-time with Arrowhead, or do they have like private practice? And
Yeah, they all have private practice, so they see patients at Arrowhead as well as the other psychiatric hospitals in the area, as well as in their own home office as well. So.
Hey, Phil, if I can just add one thing, you touched on something that I thought was super important, which is, I love that we work together, and there are so many people in this space that, I guess my closing comment would be that you really do need to do some research on people's websites and make sure you're getting a quality provider. In this space, there were a lot of people that jumped in for the money when this became the buzz at the state and national level. People that are, maybe not doing the clinical that should even be, it is mandated by the state to issue MAT and medical procedures. So I just kind of almost a word of caution about all the different options, and just making sure whoever you refer someone to, that it's a credible place. And I also would add that, what Phil said really resonated with me. There's really no wrong front door. That's what we go around saying to everybody in at least in my referral talks, and I'm sure Phil too, if they're assessed, and this happens, at our center, if someone comes in who has been drinking for 30 years, a long life term alcoholic, there is a high risk of seizure that goes with that detox. And we are an outpatient center, so we will not have a nurse with them 24/7, but Arrowhead can. So we will refer that patient to Arrowhead. They may stay there for outpatient, they may come back, whatever. But if we can get them to somebody's front door that's a quality provider, I think we're all very good about doing what is right for the patient. And that might mean that you quickly cross-refer to a different agency that might be able to service them better. I think that just hit a note with me. The real trick is to get them on somebody's books and in to see somebody, so we can try to get them into recovery. Thanks.
Yeah, I agree with that, Jean. Oftentimes, it's better now than it was, say 5-10 years ago. The Northwest Ohio area, as far as detox services, we had 32. Well, we had 32 beds, so there were like 50 beds in the area. So people were on waiting lists, and unfortunately, when you've hit that rock bottom, and Sherry mentioned that earlier, you need to get into treatment right now, and there's no time to waste. So it's imperative that we all communicate and we all work together. And if for some reason you're working with a loved one and you call a facility and they say, well, I can get you in tomorrow or next week, that's not acceptable. Don't take that for call someone else, call me, call Jean. We got into this business to help people and to help them, where they're at and in their walk. So getting them into the proper location is extremely important for their long-term recovery. So.
Thank you, super helpful. Any final questions from anyone or thoughts? I will definitely send all of you an email with Phil and Jean's contact information, and then the flyer that Jean talked about, so that you have that for reference moving forward if you would ever need it. So.
Thanks, Sherry.
Yeah.
Yeah, and if you can send the flyer to your list, that'd be great, because anybody can join that call tomorrow at noon. Yeah, that's great. It should be a lively discussion.
Very good. Well, thank you all. We appreciate your attendance and your interest in this. It's just important, and it touches all of our lives in many and various ways. So thank you, Phil and Jean and your agencies for being there, for us as we are helping those that we love. So, all right, that's it.
Thank you all.
Peace out and have a good day.
Yeah, thank you, everyone. Enjoy the day.
Bye-bye.
Bye-bye.